Ashish, we can't hear you.
Yeah, good evening. Yeah, thanks for joining in. So, if you're ready, we can start in approximately 1 minute.
Yes, we can start.
Yes. So your slides are playing?
Yesterday I saw they were playing.
Okay. Okay, great. So I think then we can start. So any programs planned in Goa?
Today we did a prematurity day thing. So we had called all our preterms, ex-preterms.
Oh, right.
Yeah, we sort of did a little function with them.
Okay. Great. Are you going for Mahapedicon?
Not Mahapedicon.
No, not Mahapedicon.
I'm going for the Neocon, Calcutta.
Oh, Calcutta. Yes. So I think it's 8:30. So we'll start the program. So I, Dr. Ashish Dongre, on behalf of Maharashtra State NNF, would like to welcome all the viewers to this Newborn Care Week. So today is a special day, especially because it is a World Prematurity Day. So the World Prematurity Day is celebrated on 17th of November every year across the globe. And this is to increase the awareness of about prematurity, the burdens and challenges which come because of babies born premature. So it takes a lot of emotional and financial toll on the parents when the baby is premature and is in the NICU. So it just to increase the awareness. So the theme for this year is that the parents embrace, which is a very powerful therapy, and skin to skin contact should be started on the moment of birth. So this is so similarly we have chosen the topic also for today is kangaroo mother care. So which is like a savior for premature baby and has saved millions and millions of lives. So premature baby, around, if you look at the WHO data, around 15 million babies across the globe are born premature. And so basically 1 out of every 10 baby is born premature. And so that's why they have also designed the logo as, so you have 9 pairs of socks with one pair which is purple color, which signifies prematurity. And they also have the color purple is used in the logo just to for the sensitivity and the exceptionality which this prematurity brings in. So with this, so today's topic is kangaroo mother care, and for that we have invited speaker Dr. Kavita Sreekumar, who is a senior neonatal consultant and associate professor working at Goa Medical College, and she has several publications to her name, and even in publications in textbooks, and she has experience since last more than 15 years. She's working in neonatology. um, so so we have specially called her for this topic, and so Dr. Kavita, you can so I invite you to start your presentation and to begin your talk.
Thank you, Dr. Ashish. So is it in slideshow mode?
Yes, correct.
So thank you, Maharashtra NNF chapter, for inviting me, and congratulations to all of us who are taking care of preterm babies. Today is World Prematurity Day, so it is a time to celebrate preterms, their families, and also us healthcare providers who take care of these babies. So in view of the World Prematurity Day, like Dr. Ashish said, the theme is parents embrace a powerful therapy, and the message map that is given by ECFNI for this year's preterm day is 3 parts. So you have empowering women, parents to enact their roles as caregivers, supporting healthcare professionals so infants can have the best start in life, and providing kangaroo mother care or skin to skin care in all settings. to all babies. So this third aspect is what we are going to speak on today. So just to start off with the numbers. So as you can see, our country tops the list in preterm births. So we have the maximum number of preterm births happening every year. And we have almost more than double of the second place that is taken by China. But then the sad part is that when we see the contribution of preterm births in under 5 deaths, there also we top the list, and almost 8.5% of the under 5 deaths are due to preterm birth complications. Whereas since China is second place, if you calculate their ratio, that is around 2.4%. I just calculated this. This is Pakistan, just just for fun's sake. Right. So how can we save all these babies? So there is enough evidence to say that if we do kangaroo mother care for all the preterms that are born with us, we can save almost 2 lakh deaths per year. So that is how powerful kangaroo mother care is, and it is a total healthcare strategy, and we will see how it justifies as a total healthcare strategy. So in my talk today, we are going to see what is KMC, what are the benefits, what are the components, how do we implement, even though we know how to implement, what are the barriers in implementation, and I will share a small QI story that we did in our unit to scale up KMC. So in simple terms, what is kangaroo care? Kangaroo mother care is defined by WHO as early, continuous and prolonged skin-to-skin contact between the mother or any other caregiver and the baby, and exclusive breastfeeding. Okay, so it is nothing but putting a diaper-clad baby skin to skin, skin of the baby touching skin of the caregiver, ventral surface to ventral surface, right? So that is what kangaroo care is. So basically, kangaroo care was first, sort of brought into practice by these two doctors, Dr. Edgar A. Sanabria and Dr. Hector Martinez. They used to work in Bogota, Colombia. And in the late 1960s, 1970s, they had very resource limitations, and they found that a lot of deaths happening in their unit. And this was by chance. They had gone for a conference in a village, and they saw that some person was walking on the street, and she had a big tumor-like thing coming out on her chest. And when they went to see it, they saw that it was not a tumor, it was actually the head of the baby. So in that time also, the midwives in those rural areas knew that the benefit of skin-to-skin contact for low birth weight babies. That is how they started this. For them, it was just loving and close relationship established between mother and child that allows the little ones to survive. And at that time also, they sort of made a policy that it is the mother and not the doctors at the hospital who is in charge and responsible for the care of a baby. So it is actually the family that needs to get involved in taking care of the child. And they just promoted KMC as just love between the mother and the baby, giving warmth and giving breast milk. But since that 1970s, there's a lot of research that has happened in kangaroo mother care. Earlier, it was just about the bonding. Then they started doing research on what are the physiological and behavioral outcomes, how they're different in KMC versus non-KMC. Then they started studying about development and pain. The research is still continuing, but there is enough research which says that kangaroo mother care can save life of the baby. And so now this era that we are now seeing is actually the era of implementation research. So even though we know that it works, but we are not giving each and every baby kangaroo mother care. So implementation research is being done in a big way. So that is how it all started. I want to highlight this paper from our country done by Dr. Suman Rao. She had done it in somewhere 2004, 2005, where she randomized babies with kangaroo care and without kangaroo care, and they compared the growth of the babies, and they found there was a significant increase in the weight, the head circumference, and the length. You cannot do such an RCT in current day because it will be unethical not to have a control group where not giving KMs, right? But then that was one of the landmark studies that happened in our country, and it is always in all meta-analysis and reviews, this study is always quoted. So finally, Cochrane review had enough evidence in 2016 to say that kangaroo mother care is a recommended therapy, because there was a very significant reduction in neonatal mortality. So 40% of the babies died less because of kangaroo mother care. There was 65% reduction in sepsis in babies who received kangaroo care, 72% reduction in hypothermia, 88% reduction in hypoglycemia, 58% reduction in hospital readmissions. Of course, improved exclusive breastfeeding at 1 and 2 months, and improved weight gain, length, and head circumference. So there was no doubt so once a Cochrane review comes out, then there is no doubt, right? So you can see the forest plots here. This is total, all the studies. So the diamond is towards the KMC, and this was a sub-analysis of low middle income countries. So in low middle income countries also, they showed it was beneficial. So there is no doubt that the KMC has a significant benefit in the preterm life. But the research continues, right? So one of the thing is initially people thought that when doing KMC, there would be a lot of physiological instability. That is why the sicker babies were not put in KMC. But then this is one of the systematic reviews which was done, which included almost 1039 preterm, published this year, and they compared babies, a group of babies who were stable with or without respiratory support in KMC versus no KMC, and they found that there was no difference in heart rate, saturation, extraction of oxygen between incubator care versus kangaroo care. So there is no need to fear that baby will have bradycardia or desaturation when putting in KMC. In fact, when they studied cerebral oxygenation done in these various studies, they found that also remained stable. In fact, that was having a slightly upward trend in babies who undergo kangaroo care versus babies who do not undergo. There's also a study which is done by Thakur et al., which shows that the temperature, heart rate, and respiratory rate saturations are better or stabler in KMC rather than open care radiant warmer that we all practice. So there was enough. Physiological stability is better in kangaroo care versus open care. And then we all do POCUS. We all want to do POCUS. So Dr. Arvind Sehgal and his team, they did ECOs, point of care ECOs in babies on KMC versus babies in the incubator. And they actually found that the cardiac contractility increased significantly in babies who received kangaroo care versus babies who were in the incubator, closed incubator. So there were also decrease in pulmonary vascular resistance. There was an increase in systemic cardiac output, which was associated with increased cerebral blood flow. Right? It is interesting because we can't be sure how this works, how kangaroo care manages to do this, but there is a positive outcome on all the physiological parameters of the baby when you put the baby in kangaroo care. The other aspect, even though there is evidence to say this, I still want to highlight it because breastfeeding is the other life-saving modality that we have. You breastfeed and give mother's milk to all preterm babies, you're saving their lives, right? And kangaroo care and breastfeeding go hand in hand. You do kangaroo care, breastfeeding is better. So the success is better of breastfeeding in early postpartum period. If you start kangaroo care, it increases the duration of breastfeeding after discharge. The mother's milk content or proportion of mother's milk that is being fed to a preterm baby during hospitalization is higher if the mother has been practicing kangaroo care. Again, at 6 months also, exclusive breastfeeding rates are better with kangaroo care. And this is another review which was published, which showed that if the kangaroo care is started early in preterm babies, they go on to feeds almost 2.5 days earlier than babies who are on open care and conventional care. Okay, so again, a significant benefit on breastfeeding. NICU is painful, it's stressful, both for the neonate, for the family. It is a painful experience. What can we do to reduce the pain? Of course, there are so many other medications. The best thing but to do is kangaroo care. And it is shown that skin-to-skin contact is effective in reducing the pain of the baby. It decreases the responses to any painful experiences. So you put a baby in kangaroo care and do a heel prick versus a baby who's in open care and do a heel prick. There is a significant reduction in the pain scores. This has been shown objectively. They have done cortisol levels, urine cortisol levels of babies in and without KMC, and they found that they're significantly lower in babies who are in kangaroo care experiencing stressful or painful situations. Other stress biomarkers are also studied like Ellen-Toyin, etc., which also have shown that the levels are low. So the stress is definitely less when babies are in KMC. And not only for babies, they have checked cortisol levels even in parents. So mothers and fathers doing KMC versus mothers and fathers not doing KMC, they have found the cortisol levels are higher in parents who do not do KMC, which means that kangaroo care decreases stress not only of the babies, but it also reduces stress of the parents. And that will go a long way on how these parents are going to bring up their babies. So it is, again, this forest plot is to highlight the PIPP scores, which is published in the Cochrane systematic review, and it is way towards the kangaroo mother care. So it is a non-pharmacological intervention which is recommended in all pain protocols. All right. So kangaroo care is one of the non-pharmacological interventions, and it is, in fact, it is better. And I found an interesting study wherein they added music also. So they had 3 groups. There was one open care, incubator care, there was a kangaroo care, and there was kangaroo care with music, right? They did not find a difference between kangaroo care and kangaroo care with music. But why I am showing this study is you can see there's a significant difference, reduction of stress in the form of reduction in heart rate, reduction in improvement in oxygen saturation, reduction in crying times between incubator care and kangaroo care or kangaroo care with music. So with or without music, kangaroo care is good. You add music, it helps. So there is no doubt that it reduces stress, it reduces pain in the newborn babies. And we all know that this stress and pain is what is going to impact the neurodevelopmental outcome of these babies. Okay, so we have to do kangaroo care if you want to reduce the stress in the newborn babies in our preterms. So there's a lot of talk about the developmentally supportive care, right? So in the 3rd trimester, the fetus is actually growing, the brain size is growing in utero. 1.5 times increase in volume and 4 times increase in the surface. So this maturation is happening, the gyri, the sulci, all these things are developing in the 3rd trimester, and the baby is born preterm. So this growth is arrested. Second thing is when the baby fetus is in utero, what does the fetus accept? The fetus is expecting to continuously getting rocked, right, in the amniotic fluid. It's swimming in the amniotic fluid. So there is a continuous sensory kinesthetic input from the amniotic fluid. At the same time, all the obnoxious stimuli from the outside are muted, right? The fetus cannot hear the loud sounds and anything else that is happening outside because it is protected in the uterus. And also the fetus is so used to the mother's diurnal variations, be it the food habits, be it her sleep rhythms, be it her movement, be it her hormones. So the fetus is used to this maternal rhythm. So the best way to imitate this or to emulate this environment is to do kangaroo mother. Kangaroo mother care stimulates all the sensory aspects of the newborn, all the senses of the newborn in the right way. It doesn't actually overstimulate, which is also not good for the baby, right? So skin to skin contact is tactile. Vestibular is when the mother breathes, right? The baby is moving up and down. So that is a vestibular stimulation. The breast milk smell, breast milk taste, mother's heartbeat, mother's voice, and visual, because that is a distance the baby can see. So the baby can see the mother's face continuously. So it's a soothing visual stimulation for the baby, unlike the lights and the things in the NICU. There are a lot of studies which have compared the neurodevelopmental outcomes, but this study is coming from our country. It was done in Calcutta, comparing the kangaroo care with exclusive breastfeeding versus exclusive breastfeeding alone without kangaroo care, and they did a DASI score, which is one of the best methods to evaluate neurodevelopmental outcomes. And they found that there was a significant improvement in the DASI score in babies with kangaroo care. And they very nicely they put exclusive breastfeeding because they know breastfeeding significantly impacts neurodevelopment. So this is the effect of kangaroo care alone. Right? So it improves the sleep-wake cycle maturation, it improves attachment and bonding, and there's a significant reduction in the amount of time the baby cries when the baby is in open care. Okay, so the best neurodevelopmentally or supportive care for the baby is kangaroo care. You don't need anything else. In fact, I came across this. They are trying to simulate it. Okay, so this is a machine which is continuously moving like the mother breathes, and they keep it inside the incubator and put the baby on it. Right, so we have the mother with us, so we have to do it with the mom and not with these. There is no need of these machines. Besides all the short-term outcomes, so now I have told you everything about the short-term outcomes and the long-term neurodevelopment outcomes. And this is almost like a milestone study. Natalie Charpak is one of the doctors who was working in Colombia, Bogota, when they actually started a study of randomization between randomized study between kangaroo care versus conventional care. And now 20 years later, they have tried to get all those participants, and they have tried to do a completely exhaustive neuroradiological, neuropsychological, behavioral assessment of these preterm babies who have now become adults. And they had almost 178 participants, which was not all of them, but it was a good number. 97 had received KMC and 81 were controls. They have published the neuroradiological findings. The other test findings are not yet published, but the neuroradiological, so this is like the most objective you can get. The gray matter volume in babies who did kangaroo care, who received kangaroo care when they were small at the age of 20 years, is significantly higher compared to babies who did not receive kangaroo care. The white matter volume was not different, but the corticospinal tract volume was higher. So this was like she has rationalized it, like the maturation is better. The brain volumes are definitely better. So bigger the brain volume, better is going to be the outcome. So we have now proper objective evidence to show that if you do KMC when the baby is small, it will have a significant impact on the brain anatomy and the brain function. Besides this, there is also a very significant impact on the social and the behavioral outcomes of these children, right? So she has studied them. The sensory deficits and the motor deficits, like cerebral palsy, were comparable in both the groups. However, she found that the protective effect against mortality at 20 years persists even at 20 years of babies in KMC. So the babies who received KMC when they were small, it's so interesting that their rates of mortality are lower than babies who had not received KMC when they were little babies. Besides that, the babies who received KMC had less antisocial behaviors. They had lower rate of school dropouts and absenteeism. Fathers' involvement was better. So kangaroo care was done by fathers as well in that unit, and fathers had less, were not abandoning their families as much. There was less separation between the parents. Also, a very interesting finding was the mothers who did KMC during that time were from low socioeconomic status. Right? So they were poor mothers. But the way they behaved towards their child, the sensitivity of theirs towards their child's needs, if they had done KMC, was as good as a mother who was educated and from a good socioeconomic status. So the whole dynamic of the family completely is impacted by KMC. So it has got short-term, long-term, and behavioral and psychological benefits and social benefits to the baby and also the family. Okay, so 1-star intervention, and we have multiple star benefits. Okay, so I think so I have hopefully have convinced you that there is enough evidence that it is really life-saving, and it is a significant improvement or impact on baby's life. Okay, so after showing you the benefits of kangaroo mother care, I will very briefly go into components, and we all know these components, right? There is no need to really go into detail. The 3 components are: one is kangaroo position with skin to skin contact. It has to include exclusive breastfeeding, which is called kangaroo nutrition. Early discharge and follow-up. It has to be followed up. So babies who go home, you have to go into the community and continue KMC and do their follow-up as well. The kangaroo position, 5 aspects. You keep the mother baby between the mother's breast. Frog-leg position, head is turned to one side. Skin to skin contact and supporting the baby's bottom. It also includes exclusive breastfeeding. So it has to be an integral part of kangaroo mother care. By the time the baby achieves 40 weeks gestational age, baby should be on full mother's milk. That is the part of kangaroo mother care. Okay, and if the weight gain is less than 15 grams per kg per day, you can fortify. But basically, it has to be more and more of mother's own milk. Early discharge follow-up is also a part of kangaroo care. If you're doing kangaroo care, you have to follow them up after discharge. It was found that babies who do kangaroo care get discharged earlier, but you have to give support at home as well, because if they continue kangaroo care at home, it is seen that community acquired infections are also less. Nosocomial infection risk is also less. So it is important that we integrate with community health services when we discharge the baby and when the baby goes home. So how do we implement kangaroo care? It is not difficult. One is who is eligible. So earlier people used to say that, less than 2000 grams, let them become stable, let them come off oxygen, let them come off IV fluids. That was the earlier thing. Stable twin babies, yes, you have to do KMC. But now there is no restriction. Babies on oxygen, babies on IV fluids can be started on kangaroo care. Babies on oxygen, you might want to put a pulse oximeter. Babies on CPAP, you can do kangaroo mother care very safely. Babies on ventilator also, you can do kangaroo mother care. We have done kangaroo mother care on babies on ventilator because a mother insisted. The baby was on kangaroo care. She was doing well. Suddenly she deteriorated. And the mother was completely stressed. She said, I want to do kangaroo care. So we had to put the baby in kangaroo care because she insisted. And it was so amazing. The oxygen requirement, the pressure parameters, everything just started coming down. So again, ventilated sick babies also, you can do kangaroo mother care. The only thing is hemodynamic stability has to be there. So which babies are eligible? All low birth weight infants. All babies less than 2000 grams have to be put in kangaroo care. When to start? There are studies to show. In fact, all are worried about preterms, BPDs, late onset sepsis, right? So when you do early KMC, that is within the first week also, you can reduce the risk of CLD and reduce the risk of nosocomial infection. However, WHO recommendations have been launched today. There was a webinar at 5:30 in the evening, and they have said that they have updated their recommendations. Earlier, they recommended when the baby was stable. Now they have recommended that it has to be a routine care for all preterms or low birth weight infants. It has to be initiated in the healthcare facility or even at home, and it should be given for 8 to 24 hours per day. That is one thing, and there is strong recommendation and high certainty evidence. And when to start? WHO has now recommended to start immediately after birth, at least within 24 hours. That is a strong recommendation with high certainty evidence, right? So the guideline given today by WHO is that you have to do it at least for 8 to 24 hours, 8 hours per day minimum, and start within 24 hours. That is the recommendation for kangaroo. So early, and it has to be immediate. So there was so I'll highlight this study which is published in NEJM done by WHO. Dr. Sumanna was one of the investigators. So what they rationalized was that preterm babies, the death rate is maximum in the first 24 hours. But in the first 24 hours, we are not even giving kangaroo care, right? So if we know that kangaroo care saves life, but we are not providing it in the first 24 hours, how is it going to, how is it going to benefit in the community or on the population basis? So that was the rationale of doing this study. And this was called the WHO Immediate KMC Study Group. The question was, does continuous KMC initiated immediately after birth compared with current guidelines? At that time, when the study was done, guidelines were when the baby stabilizes. So whether it will improve survival. So it was a multi-center, multi-country study, randomized between babies who were started KMC after stabilization versus babies who were started KMC immediately after birth. So they included babies between 1 to 1.8 kgs. All even CPAP babies were put in KMC, and they managed to do KMC at an average of 2 hours after birth, which was so good. And for this purpose, they made a MNICU. This is called a mother and neonatal unit. So the mother and the baby remain in the same place. So there is a bed for the mother with adjustable back support, so she can do KMC there. There is a warmer, ventilator, monitor, and CPAP, and everything is in the same room. So this is called the MNICU. So for this study, MNICUs were made at all the health center at the study sites, and they got 17 hours per day. They managed to do the duration of KMC was 17 hours per day, which was obviously it had to have an impact. And what did they find? They found that the death between enrollment and 28 days of life is significantly less. So this was a hard outcome. Babies are dying less compared to babies who are not put in immediate KMC. Okay, so what was the recommendation given by the study? Conclusions were immediate KMC for 1 to 1.8 significantly reduces risk of neonatal death by 25%. Immediate KMC provided to every 27 babies only will save lives, which translates to 1.5 lakhs of babies' lives, preterm babies' lives saved every year. And MNICU is going to be the new thing that we are going to start working on. So when will you start KMC? Immediately. Where to provide? It can be provided anywhere. You are NICU, MNICU, a KMC ward if you have. It improves the uptake of KMC in the home with the help of community health workers. But the bottom line is it has to be standard of care. Every baby has to be in KMC. In fact, kangaroo transport is also being studied. So putting the baby in KMC and sending is what is going to be recommended now. How to provide? Very few things are needed. You either have a semi-reclining chair, or if you don't have a semi-reclining chair, put the baby mother on a bed and just give support with pillows. You can use a KMC sling bag, or you can use a KMC sling, but a simple dupatta or a sari just to tie the baby around, and there is nothing else needed. But the most important thing while doing kangaroo care is you have to counsel the mother before you start kangaroo care, because it is scary for her. The baby is on CPAP, the baby is on oxygen, you're going to give it to her and she will be so scared. So you need to counsel her. It has to be one-on-one counseling. It has to be done like on a regular basis. And very important part is to do it before she starts KMC. You need to talk to her, allay her fears, and tell her the benefits of KMC. And continuous support is, we have found that group counseling is also very helpful when it comes comes to KMC. Who can give? It is called Kangaroo Mother Care. WHO recommends to call it Kangaroo Mother Care still, but says that it can be given by father or grandmother or any other family member. So any family member can give KMC. Now, how long to give KMC? So when you pick the baby up, especially babies on respiratory support, you're going to cause some instability in saturation. So the recommendation is once you start the session, you have to give it for at least 1.5 hours. So short is 4 hours, extended is 5 to 8 hours, long is 9 to 12 hours, and continuous is more than 12 hours. But the interesting part is that when a systematic review was done about the duration of KMC and the advantages, it was seen that if you do it for more than 6 hours only, you get the benefit. Less than 2 hours, if you do, the benefit doesn't remain, right? And so at least 6 hours, but now WHO recommendation is 8 hours. So now we are going to think that KMC has to be done for at least 8 hours per day. Okay? Till when you continue, till the baby says, I don't want, baby starts wriggling out around 2.5 kilos, that is when you will stop. Okay, so how long? Continuous. So we know all these things, but still when we actually do an evaluation, we will find that only 1 in every 4 preterms are put in skin-to-skin contact after birth. And in government setups, at least it is much better because we have less resources. But even in private setups and all, there is a lot of resistance to do KMC. A lot of resistance for families to enter the NICU and start taking care of the babies. So why everybody is not doing? When they started studying, when they did a scale-up research, they did an implementation research, again guided by WHO. They found that in the periphery, the KMC uptake is low because one is they did not have weighing scales to identify low budget babies. The health workers did not have enough knowledge. There was lack of space and infrastructure, lack of priority and leadership support, staff availability and training, and community acceptance also was slightly lesser. Those were the reasons. So what they did was they made a model to scale up. And again, it was a multi-site, India and Ethiopia. These were the 2 centers which were chosen. And this was a community implementation of KMC. So one was pre-KMC. So they provided weighing scales for accurate birth weight recording and referral to a center which can do KMC. For the KMC, they made infrastructure changes, staff training, motivation, and support. And post KMC, they integrated with the community services so that they can be followed up at home as well. And what did they find? They found that there was improvement in the rates of initiation, especially in the Indian sites. They found that 87% of the babies were put in KMC. 60% received for more than 8 hours at the time of discharge, and 52% continue to receive KMC at home even 7 days post-discharge. So what do we study from this scale-up study? One is you have to do implementation research if you want to scale up KMC and provide it to all babies who are born low budget in our country. There has to be a strong government leadership. It is not something that you can do in your healthcare unit without the leaders being involved. The leaders have to be convinced, the government has to be convinced that it is going to reduce, and it has to be a healthcare strategy which is advocated by the government setup as a policy and protocol. And you need to provide basic KMC units and ecosystems which need to be encouraged that keep mother and baby together rather than separate them. So this was one of the scale-up study which we can learn from and take points to improve our KMC uptake. COVID had affected, but this study we did some calculation, and they found that even if you take an imaginary transmission rate of 100%, so every COVID positive mother who puts the baby in KMC, baby gets COVID. Let us assume that. Even with that, they say that the life saved by KMC was almost 1.25 lakhs compared to deaths due to COVID. So what we study from this COVID pandemic is that there is no need to separate the mother and baby even during a pandemic, even if she's infected. She just has to wear an N95 mask and keep good hand hygiene and continue Kangaroo Mother Care, because that is going to save the baby's life. Okay, so that is what we learn from this analysis. So zero separation policy was what was being advocated during COVID, and separating infants from their mothers and families is harmful for the baby. So it is not only that it impacts neurodevelopment outcome, it is actually harmful. It is toxic to the baby. So zero separation policy has to be followed, and you can see Dr. Suma and Dr. Shashivani, these are the stalwarts who in our country have built up KMC uptake. So I will now share a quality improvement, because I know many of you in your units must be not doing KMC for so many hours in all the babies. In our unit also, we were not doing. We used to write Kangaroo Mother Care. My residents used to write on orders KMC ALAP, Kangaroo Mother Care, as long as possible. So we thought Kangaroo Mother Care is going on, right? But one of the fellows realized that it is not happening. It is not happening. So when we actually started documenting it, we realized that we are giving Kangaroo Mother Care only for 4 hours, 3 to 4 hours per day. So then we did a QI project. We planned a QI project where we wanted to increase the duration of kangaroo care in babies less than 1800 grams from 4 hours to 8 hours, and we planned it over 6 weeks. When this is called a fishbone analysis, which you do in QI, there was no written policy. Like in our NICU, we have a policy of respiratory distress management, CPAP, surfactant, feeding, TPN, infection control, CLAPSI, all the other things. But we did not have a KMC protocol. Mothers were not motivated, they were not educated, residents were not involved. Residents and doctors felt that it was a nurse's job. Staff nurses were overworked. Again, not introducing KMC early, not counseling in the postnatal wards. So we planned many changes. We did PDSA cycles, and some of them were, one is written policies, documentation. So where the nurses were writing input output, like how much feed was given, how much fluids are given, what drugs are given. In that same sheet, we made them document in every shift how many hours of KMC they had given. The next day, when the resident used to write rounds of the babies, on the left-hand side, they write input, output, urine output, weight, etc. We told them to document KMC hours from the previous day. So we knew that which mother needed to be counseled, which baby is not getting KMC. So, and you could keep a track of the number of KMC hours that were being done. We had weekly counseling sessions for the mothers as well as the family members. Fathers started coming in. We kept a specific time that fathers have to come in and start doing KMC. And if the mother was not well, we started getting family members involved and identifying surrogates who could come into kangaroo care. So at the end of our QI project, we from a mean duration of 3.5 hours per day, we went up to 8.6 hours per day in 6 weeks' time. The fathers who were not coming inside started doing an average of 3 hours of KMC per day, right? And the difference was significant. So if you want to scale up or initiate KMC in your unit, one way to make a change, or the best way to make a change, is through a QI project. Because just by telling people to do it, it doesn't happen. Form a team, get a smart aim done, document your KMC hours, and then work on it with various PDSA cycles. So that is how, this is one of the examples how you can work on your KMC initiation in the unit. So finally, my key messages: one is, it is feasible. Everybody can do it. It is natural. It is supposed to be done if the baby is born preterm. Cost effective, evidence-based now, and it is a therapy. It is not something that you just casually give. It is a therapy now. It should not be considered as an option. It has to be the standard of care. You have to do it regardless of where you stay, how rich or how poor your NICU is. It has to be done as early. In fact, it should be done immediately, as long as possible. Very important is emotional and educational support to the mother and the family, and also to healthcare professionals. So with that, I thank everyone for your patient listening. Stop sharing. Thank you.
Yes, thank you, Dr. Kavita, for explaining so well the positive aspects and the benefits of KMC. And it indeed, if you look at the benefits, you rightly said that it prevents around more than 2 lakh deaths per year. And I think you also, as you showed the quality improvement project, I think every unit should have, because they feel they are doing KMC, but sometimes, the hours are just not sufficient to see the real positive benefits. It was also interesting to know from your talk about the way it improves with cardiac contractility, and you can see the benefits of KMC even after 20 years. I mean, when the child is 20 years old, which is such a long-term benefits. And I think the day is not very far when like every NICU will have MNICU like with mother, and they will implement KMC like within hours of birth. I mean, that's our goal. So yes, thank you so much for your wonderful talk. And so I'll just check if there are any questions in the chat box. So I don't see any questions in the chat box. So I'll ask you one question. So any condition in which KMC is not to be given?
So I think as of now, hemodynamic stability would be one thing. So if the baby is like say on inotropes
Yeah.
or having not maintaining very well high ventilator parameters, that would not be a good time. If you're just starting KMC, I think CPAP you should initiate first. Once your staff is very used to with CPAP and oxygen and IVF, then you move on to ventilation. But one is hemodynamic stability and one is respiratory parameters or requirements should not be very high. It should be more like baby should be more stable, oxygenation wise.
Right. And say suppose we have given a baby for KMC. So how do we monitor such a baby? Say suppose a baby is on CPAP and so he's on with the mother for KMC. So do we like routinely as we monitor for a baby who is in incubator, we do the overall monitoring in a similar fashion or?
Yes. So babies who are on CPAP or oxygen, when they put in KMC, it is recommended to put a pulse oximeter. But you know, it sometimes babies are on CPAP for so long. Our preterm babies, especially extreme preterm babies, remain on CPAP for so long. If once your staff gets experienced, I have seen that my staff also, initially they always insisted on a pulse oximeter. But once they get experienced as to see that the baby is breathing well, they try to see the color of the baby. They can identify if the baby is, desaturating or destabilizing in kangaroo care. But if you want to begin with, if you're putting a baby on CPAP or oxygen in KMC, then you have to have better to have a pulse oximeter attached. That is how you will monitor the saturation, the heart rate.
Right. So thank you so much. Those were the questions, and thank you for this wonderful talk, and especially on the day of World Prematurity Day. I think it sends a clear message that KMC is standard of care and it has so many huge benefits. Yes, thank you so much.
Thank you. Thank you so much. Thanks.
Okay, so with this, then I'll end the session. Thank you all for joining in. And we'll see you again on Saturday. So for another interesting talk, because we're having this newborn care week going on full week. Thank you so much.
Thanks, Prakash.
Thank you so much.
Thank you.
Thank you. Thank you.